Okay, good morning or good afternoon or good evening, everybody. This is Sophia DeLaviore with the Reproductive Health Supplies Coalition. Thank you for your patience. We will be starting the webinar in just a few minutes. We'll wait till a minute or two after the hour. Just as a heads up, all attendees are automatically muted, and you will hear me give this same speech in a little bit as more people join. Thanks everyone for joining. Hello again for those of you who have just joined. This is Sophia DeLaviore with the Reproductive Health Supplies Coalition, and we'll get started in just another minute or two, and I'll open up the webinar and do a little housekeeping before turning it over to our Safe Abortion Workstream leads. Okay, so I'm going to go ahead and get started because we have a lot of great content to get through today. This is Sophia DeLaviore with the Reproductive Health Supplies Coalition, and thank you to everybody who is joining this webinar. I'm first just going to start with a little bit of housekeeping, which is just to let you know that all attendees are in listen-only mode, so you will all be automatically muted just to limit our background noise during the presentations. And what we'll do for question and answer periods, which will indicate when we're entering a question and answer period, you'll see there's a questions box on the webinar platform that you can type in your questions. You'll also see, if you look in the attendees list, you have the option to raise your little webinar hand, and if you do that, then I can try and unmute you individually so you can chime in during the question and answer. But please feel free, because we'll do a few presentations and then open it up for questions, to type in your questions as those presentations are going, and then our workstream leads will moderate that question and answer and read those out loud during the discussion period. And if you have any questions or any issues come up, you can also put that in through there. I just wanted to also give an exciting update. As many of you have probably seen in your emails, we have landed on a rescheduling for the general membership meeting. It will be March 20th to 22nd, and it will be in Brussels. So something that's different is that it's a 3-day meeting as opposed to a 5-day meeting, and that's to make it a little easier for people to make the trip and also some cost savings for everyone involved. So what that means for the NURHT meeting is actually it's the same length as it was originally going to be, as the NURHT is usually just a half-day meeting. There will be one full day. The Tuesday is going to be all of the RHSC implementing meetings, and I believe the schedule is still being fully confirmed, but NURHT is likely to be the morning of that day. And then we will have plenary the following 2 days. So we will be regrouping as a caucus and with the Safe Abortion Workstream in mind as to how we'll reorganize that agenda. But Safe Abortion will certainly still have a slot there, although as you can see on this webinar, we're covering a lot today, so hopefully we'll have some great things to follow on from that. Okay, I think other than that, I'd like to turn it over to our workstream leads, Jennifer Blum from Gynuity and Nathalie Kapp from Ipas, who are leading this workstream and will be moderating this webinar. Thanks, everyone.
Thank you so much, Sophia. So this is Nathalie Kapp speaking, and you'll hear from Jen a little bit later in the webinar. I'm just going to start off with the agenda, which is the next slide. If you could change the slide for me. And what we have today are, we'll be starting off with our hearing about the innovation grants that were given out last year to various projects, and there were 4 of them, and we'll hear from each. So we'll start off hearing from Mariana Romero at Caucus. Then we'll hear from Patrick Jamo with Ipas, and then Erica Chong with Gynuity Health, and then finally with Heather Clark at Population Council. After these 4 presentations, we'll have a few minutes, maybe about 10, to address your questions, and then we'll move on to the second half of the meeting. So let's start off with Mariana Romero, who will be talking to us about increasing access to safe abortion with medicines in 6 Latin American countries.
Hi, good morning, everyone. Thank you for attending the webinar, and thank you for including our project in this presentation. Can I have the next one? Okay, this project was a collective endeavor coordinated by Ruth Surbriggen. I was a consultant along with Sonia Tarragona, and we had local people conducting each of the country studies. The next one, please. The purpose of this project was to strengthen strategies of drug registration, misoprostol and mifepristone, for legal abortion in countries in the Latin American region. We wanted to systematize and analyze barriers to registration, availability, and access to the 2 drugs that are suggested and recommended for medical abortion. Not only for legal abortion, but also for obstetric use, and also to gather and systematize successful and failed registration processes in order to identify some facilitators as well as obstacles through the process in registering these drugs in the countries. The next one, please. Why we wanted to do this is because in Latin America, abortion is permitted under the health indication, but some of the governments have been inactive or have not been reasonably active in order to approve or register these 2 drugs, even when there's enough public health concerns as well as maternal mortality indicators in particular that will justify to approve the drugs. And at the same time, we have to keep in mind that most of the national laws in Latin America accept or justify abortion as a legal practice within the norm. The next one, please. So we developed an instrument that could be applied in the 6 countries, addressing dimensions such as if there was a registration agency, if there was any approved drugs already in place, and if that was the case for MISO or MIFE, we wanted to know about indications, route, dosage, the insert characteristics of it, and also prescription requirements. For example, age or any other concerns that, or only institutional, only institutional ways of buying the drugs and not by private physicians, for example. We wanted to know if there was public production or it was local or imported. We wanted to know if MISO and MIFE were included in national guidelines or institutional guidelines, specifically for safe abortion or post-abortion care. We wanted to know if MIFE and MISO were included in the essential medicine lists of each country, and any attempts that were in place or being done in the past to register MIFE and MISO, and what was the result of it. The next one, please. So by contacting local consultants, we applied this instrument to 6 selected countries. And we did this was an arbitrary list, of course, but we did it taking into account any registration attempts, also political will to change the law or to change the protocols, or existing protocols that include legal abortion and the provision of MISO and MIFE in those protocols. So those were the 6 countries that we selected: Argentina, Bolivia, Brazil, Colombia, Peru, and Uruguay. The next one. Just to move quickly to the results, what we found is that Argentina and Colombia had attempts but failed to register MIFE or MISO for abortion indications. And I have to say this, that Colombia is now, they do have MIFE and MISO registered, but at the time we did the study, this was finished by January this year, MIFE was not registered yet in Colombia. Bolivia, Brazil, and Uruguay had tried to register the drugs and have succeeded. I have to mention that only Uruguay had MIFE and MISO by the time we did the study, while Bolivia and Brazil had MISO. Peru hasn't undergone any attempts to register MIFE and MISO, but for legal abortion, but there's almost 9 commercial brands that are available of MISO in Peru at the same time. And that what we found by doing this study is that mostly political and economic motivations, more than any other technical requirements, were the facilitators to register the drugs. And at the same time, religious or conservative factors seem to explain the barriers and obstacles in making these drugs available at the country. The next one, please. So the products or results of this study was first a document with the systematization of country cases and status of MIFE and MISO registration and availability, indications and cost. And I have to say it was a very useful tool. We provided not only like a narrative of the whole process, but tables comparing the situation of the 6 countries. And from the feedback that we have had so far, these tables and the systematization was very useful for a lot of the countries. And we tried to draw some lessons learned from the processes by interviewing the actors that were participating in the process, and we were able to draw some obstacles and potential obstacles for future registration in the region. That's it. Thank you very much.
Thank you so much, Mariana. And for those of you in the audience who have joined a little bit late, what we're planning to do is to take questions after our first 4 presentations on the innovation grants. In the meantime, if you have questions, you're free to write them, and we will get to them during our question period. Also, for those of you who have asked about the slides being cropped slightly on the side, we're trying to change the settings, and hopefully it will be not cropped anymore. Anyway, we're working on it. Our next speaker is Patrick Giemmo with Ipas, who's going to speak about mobile supply management tools for abortion commodities.
Yes, thank you, Nathalie, and welcome to the audience. I'm going to speak, as Nathalie said, on the mobile supply management tool for abortion commodities, which Ipas implemented in Nigeria. Next slide, please. Yes, the Ipas piloted the mobile application tool, which helps in calculating the MVA and MA supplies required for each facility, and looking at the potential advantages of the mobile tools, which were the tool may be easier to use and more accessible to providers working in these facilities. The tool did not need the internet or a computer, as opposed to the previous tool, the pre-existing tool that we were using. And the result can easily be emailed or texted to share information immediately after the calculation is completed. And the use of this mobile application had also the potential advantage to prevent stockouts. As you know, when there are stockouts, there are no services, and access is hampered. So the goals of the project were to pilot, test the mobile tools with supply managers and providers in a real-world setting, and test the tools in the public sector and private sector supply chains to assess accuracy and feasibility and usability, and make changes to applications before dissemination. Next, please. So these are the steps that were undertaken during the pilot. The first step was the recruitment and training. So we recruited 47 participants from 2 states in Nigeria. And these participants were mostly providers who managed their own supplies at their own facilities, and predominantly they were from the private sector. And the training was a 1-day training in each state, during which we provided an overview of the project. We helped in downloading the application, and also conducted some practice scenarios to use the application and apply to supply needs. And also did some practice on emailing and texting the results. Next. Then went into data collection. We had participants, and the questions were focused on how participants calculate their needs, how they report, how they order, and how their use of the new application, the experience was with regard to the use of the application, as well as the reporting of the results. Then a 3-month collection of data. We had a usage log. Every participant who used the application had to log into a usage log. And after that, we had the 10 users who participated in more in-depth qualitative interviews at the end of pilot study. And I'll show you what the results look like. Next. So on this graph, we are showing a comparison between, regarding the ease of use of the mobile MVA-MA calculator comparatively to the pre-existing method. So on the left, we are showing how easy, the question was how easy it is to use the previous and current process for calculating MA and MVA supplies. As you can see, using the pre-existing method, we had responses which spread from easy to do not know, and none of the responses were under the very easy bracket, contrarily to the use of the new mobile MVA and MA calculator, where we scored 68% of users who felt it was very easy. And on the right-hand side, we have the results on how easy it was to order using the MVA, using the mobile MVA-MA calculator. And the findings are similar to the ones on the actual easiness for calculating. But here we have 75% of respondents who felt that the mobile MA MVA calculator was very easy and comparatively to the, in comparison to the pre-existing method. Next. We also, as I said, did an in-depth interviews with a number of users, and looking at the perception of data quality. Users felt, I mean, the question was, how do you feel about the quality of data for the MA and MVA supply management? Comparing again the pre-existing method to the mobile calculator. With the pre-existing method, the highest level of perception, I mean in the positive, was good quality, whereas with the new mobile MVA, the perception was very good, with more than half the respondents. Next. So just a summary of the findings. The tools have the capacity to accurately provide an estimation and ensure continuously availability of abortion commodities for private and public health facilities. And that accuracy is very important to availability of services because it prevents stockouts. But the tools can also be used in public sector and private sector supply chains, though some users may have trouble downloading it at first on their devices. This is basically because of the internet connection quality. And the scaling up of the tool for supply management among service providers, suppliers, and supply managers in Nigeria and in other countries, for that matter, is very feasible. Next. And we wish to thank the Reproductive Health Supply Coalition for the Innovation Fund grant, and as we present these results from this activity. Thank you.
Thank you so much, Patrick, for that presentation, and also thank you so much for our speakers so far for keeping to time. There was a question from the group about the slides being cut off on the right side, and I just want to say that if you expand, if you go up to the upper right corner and hit expand, it'll make the slides look complete. So if we could have the next slide, we'll move on to our third speaker talking about the innovation grants. We have one more after Erica, and then we'll take questions for all four of our speakers. Erica Chong is from Gynuity Health Projects, and she's going to be talking to us about dissemination, information sharing, training, and awareness raising of the potential for a simplified medical abortion strategy with a multi-level pregnancy test in Kazakhstan. Erica?
Hello, everybody. Thanks so much for joining the webinar, and thanks very much to the Supplies Coalition for inviting us to share our findings today. As Nathalie mentioned, our project was involved awareness raising for a simplified medical abortion strategy with a new kind of pregnancy test. Next slide, please. So the project took place in Kazakhstan, the largest country in Central Asia. It has a population of almost 18 million that's quite spread out since it's a very large, covers a large geographic area. Next slide, please. So one of the reasons that we did our project there was partly for the size of the country and how far away women can be from services, but we also were interested in working there because their medical abortion protocol is fairly cumbersome. It requires 4 in-person visits, so the number of visits can often deter women from choosing that method, even if they prefer it over surgical abortion. So the 4 visits, the first visit involves clinical assessment, so that all lab work and some other tests. The second visit is only to take the mifepristone. The third visit is for the misoprostol administration, and then the 4th visit is for follow-up. So even though it's quite cumbersome, thankfully the Ministry of Health and other decision makers are interested in making it more streamlined. They're interested in applying some of the new findings and that are in the literature and in other places. So we've been working with partners in countries since 2011. So they were open to trying something else. So in addition, so there is a multi-level pregnancy test that's available in country. There is a distributor who was distributing it on a very small scale, only basically to individual providers. So for the most part, providers are not aware of how to use the test in medical abortion, how to integrate it into services, and women had very little or no information about how they could use the test in their abortion care. Next slide, please. For those of you who may not be familiar with the multi-level pregnancy test, it's different from the normal kind of test that you can get in the pharmacy that just gives you a yes or no readout. Instead, this test detects the approximate concentration of HCG within 5 specified ranges. And since HCG drops rapidly after medical abortion, if you use 2 tests, one when you first take the mifepristone and then the second about 1 or 2 weeks later, when the levels fall, that's how you can detect if ongoing pregnancy is not there. So if there's a decrease in levels, then there's no ongoing pregnancy. If the levels are the same between the 2 tests, or if the levels increase, then there's a possible ongoing pregnancy, and we usually counsel women to seek further care. So the test that we used and the test that was available for sale in Kazakhstan is the DBEST test. There's several different tests that are available globally, but we used the DBEST one, partly because it's highly reliable and efficient. There was recently a meta-analysis of 7 studies that came out this year and found that it was highly efficient for excluding ongoing pregnancy after medical abortion for women who are 63 days or LMP or less. Next slide, please. So our objective was to disseminate evidence on the simplified medical abortion strategy using the MLPTs. And we partnered with the Kazakhstan Association on Sexual and Reproductive Health, also known as KMPA. One of the activities that we did was we conducted a series of meetings and trainings. So there was a regional meeting in September of 2016 in Tbilisi, Georgia, and we convened about 60 or 70 international experts on medical abortion. And there were providers from Moldova and Uzbekistan there who had experience in using the MLPT. And we brought about 5 providers from Kazakhstan, so they had an opportunity to hear updated data on the MLPT and to talk with providers who actually have used it before and have a quite positive experience with it. We also had a training on the MLPT with some providers from clinics in Almaty and Shymkent in January of this year. And this was sort of before we conducted a clinical study, which was funded through a separate grant where providers got an actual experience in using it with patients. And then once that study was concluded, we had a dissemination meeting in September of 2017 to disseminate the results from the study, and also we were able to share some of the materials that we had created about the MLPT, both for providers and for patients, which I'll talk about in the next slide. So that dissemination meeting was with about 70 providers, and it generated a lot of interest and local support for in-country registration of an MLPT for pharmacy sales. Next slide, please. So some of the materials that created, one that's not mentioned on this slide is an FAQ sheet. It's a two-sided one-page sheet in Russian that describes the MLPT strategy. It's mostly targeted to providers and other decision makers on how the test works and how you can use it in service delivery. We also created pictorial instructions using simple language in Russian and Kazakh on the use of the MLPT for medical abortion and follow-up. So it describes how to use the test, how to interpret the results, and it also has space for recording the two results for the two tests. So we piloted those information materials with some women in Almaty, and then we sort of made some adjustments based on their feedback before finalizing those instructions. And lastly, we created a video, a YouTube video on the use of MLPTs for medical abortion follow-up. Currently, the video is available in English, Spanish, and Russian. The link to the video is on the screen, but if you can also just go to Gynuity Health Projects channel on YouTube, and you can find all the videos that way. And the video is about 2 minutes long. So I will stop there. Thank you very much.
Thank you so much, Erica. That was a great presentation on Kazakhstan, and we will move into our last presentation on the innovation grants. We'll hear from Heather Clark on ensuring access to safe abortion supplies.
Thank you, Natalie, and thank you everyone for joining today. I will be presenting on an effort led by the Population Council to develop, to document gaps along the safe abortion supply chain. And many of you have joined the NURHT call, I think it was 2 weeks ago, where I gave a longer version of this presentation. So today I'm going to give an abbreviated version of this. Next slide. So this effort was generously funded by the RHSC's Innovation Fund, and it was, well, access to high quality safe abortion supplies and services can significantly reduce maternal mortality and is essential for addressing this. It's essential to address this as a public health priority. So the aim of this document was to document gaps and challenges to ensure access to safe abortion supplies. And many of you on this call have already and continue to conduct work on safe abortion supplies. And this effort was to pull all of this work together and identify what gaps still remain. And in fact, we just heard from fellow presenters about innovative solutions they're working on to address some of these challenges, which are included in the full report that was produced. So we hope that this report can serve as a guide for global policy and decision makers, as well as future investment in safe abortion supplies, as there are still many challenges to address before women can realize their right to safe and legal abortion. So we conducted this by doing a document review, including peer-reviewed journals, gray literature, donor reports, briefs, anything we could really get our hands on. And many of you on the call were instrumental in referring us to particularly useful documents that weren't necessarily available via normal document review processes. So the supplies, we also did stakeholder interviews by phone with researchers, distributors, manufacturers, and donors to supplement the document review. The supplies we focused on are mifepristone and misoprostol for medical abortion, and manual vacuum aspiration. And I also want to recognize that we had considerable input from, as I mentioned, many of the organizations that are participating today, and in particular, Ipas and Gynuity, who provided technical support. Next slide. So we attempted to look at various elements of the supply chain, manufacturers and distribution, registration, quality, forecasting, procurement and price, product use, and demand generation. Next slide. So in the interest of time, and because I presented on an expanded version of this earlier, I'm going to sort of skip over the findings and get right to the recommendations. And there are 9 recommendations, which I'll discuss on 2 slides. They're not in any particular order. They sort of follow the order of how the report was structured. Okay, so I'll start with the recommendations. The first one is to increase the number of high quality products registered at the country level and remove substandard products from the market. So substandard misoprostol quality continues to be a barrier to providing safe abortion services, and technical assistance to generic manufacturers to improve quality is needed. In addition, sharing the knowledge regarding quality of products already available with procurers and ministries of health could help ensure appropriate procurement and the supply of safe products. The second recommendation is to better understand the regulatory environment to accelerate product registration. The ever-changing regulatory environment poses challenges to registering medical abortion supplies in country in a timely fashion. And countries often add requirements for registration that contribute to delays in getting a product into a country. Further, there's a high cost to register a product in a small country with a poorly developed market. It's often not a viable option as there's little or no return on investment for manufacturers. So strategies to overcome the high cost to register and deliver supplies in these settings could be developed. Number 3 is to provide guidance on the usage of supplies in lower resource settings. Best practice for manual vacuum aspiration instruments requires accompaniment by effective training, and linking the MVA kit availability with training opportunities can ensure that MVA supplies that have been ordered are not sitting on a shelf due to lack of training, and that they are also maintained well when in use. And instructions for appropriate use of mifepristone and misoprostol can also be improved. Number 4 is to strengthen country-level inventory and forecasting mechanisms. Similar to other RH products, these systems could be improved. Often MVA kits are not in use because a very inexpensive part is missing, or there are stockouts of mifepristone and misoprostol. So strategies to integrate inventory and ordering into existing mechanisms for other reproductive health supplies could be developed, and sharing inventory with service delivery networks is one way to address this problem. And number 5 is to develop advocacy campaigns or tools for women to know their right to a safe and legal abortion. So often women do not know they are legally permitted to obtain an abortion, or they are not aware what safe abortion options exist or where to access them. And when women in communities know their rights, the demand for effective contraception and safe abortion supplies will increase, thereby decreasing unsafe abortions. Next slide. Addressing stigma in supplies availability is the next recommendation. There has been much research conducted on stigma among providers and families, causing barriers to accessing safe and legal abortions. But stigma also exists along other points in the supply chain, which need to be explored. For example, the Ministry of Health. Further guidance on better integrating abortion supplies into a package of family planning and reproductive health services could help overcome some of these barriers to access related to stigma. The 7th recommendation is to conduct research on price and devise price reduction strategies where needed. The cost of safe medical abortion services does vary significantly by country. In some countries in which mifepristone is registered, medical abortion services with mifepristone and misoprostol regimen is provided through the public sector and is highly subsidized. In other countries, women have to pay out of pocket for their medical abortion care, with a wide variation in price by sector, as well as by the type of provider. In some countries, misoprostol is available directly from pharmacies and is relatively inexpensive, and in other countries, it may be considerably more expensive. So a global review of price, perceived value, ability to pay, as well as strategies for price reductions would be beneficial. The 8th recommendation is to update essential supplies lists, EML lists. Mifepristone and misoprostol are currently on WHO's Model Essential Medicines Complementary List. And with countries starting to put more value into EMLs, ensuring mifepristone and misoprostol is on country EMLs could help ensure these supplies are integrated into country programs. And the final recommendation is to communicate with the larger reproductive health and rights community regarding safe abortion supplies issues. Limiting funding for safe abortion supplies was viewed as a major barrier to addressing challenges along the MBA and medical abortion supply chains. So more work needs to be done to reach national and local governments, as well as NGO service organizations, private sector partners, and civil society groups, and the donor community to brief them on the supply chain issues. And that brings me to the next and final slide. And so this slide, for those of you who—
This is Jennifer. Sorry, I just want to interrupt
Yes.
just because we're about 3 or 4 minutes over. If you could try to just wrap this up so we could leave time for questions. It's very interesting with
Okay.
the Q&A. Thank you.
Sure. So the final slide is just some thoughts on where we could take this, where the information in this report could go next. So it's really just some steps for the consideration by the Safe Abortion Supplies Workstream on what to do with the full report, which will be disseminated, and the recommendations in that report. So, and I'll leave you to read this and think about it further. And but brainstorm global and country level implications, complete identification of ongoing efforts. An effort was to document that was included in the full report, but some more work could be done. Identify relevant activities by recommendation, collaborate on funding proposals, and leverage existing funds to work on some of these activities. Develop country-level tools to help operationalize recommendations and further disseminate recommendations. And that concludes the presentation. So I'll turn it back over to to Nathalie and Jennifer.
Thank you. Thank you so much. We appreciate hearing about your this landscaping paper. I think it can really help us talk about what we want to do with this work stream. So we'd like to take about 10 minutes, maybe a few less if we don't have lots of questions, for questions. So we're taking questions for any of our panelists, and what I would invite you to do is to write your questions either in the question box or in the chat box that you see on the right-hand side of the screen. I'm going to start with one that we received while Patrick was speaking. And while Patrick is answering, I encourage people, if you have any questions, to go ahead and write them. So this first question is for Patrick. And the question is, did you encounter any stigma or reluctance among the private sector providers related to using the app?
Thank you very much for the question. The app was used with private providers who are actually Ipas trained providers and in Ipas supported facilities. Ipas has a program in Nigeria which is based. So these are well-informed providers and who are supportive of the women's rights and to access to safe abortion and quality post-abortion care. So that did not occur.
And Patrick, can you tell us if there are plans to make this tool available either throughout Nigeria to anyone who wants to use it or beyond?
Yes, the tool is actually available in different forms. It is actually available in English, in Spanish, and in French. I'll try to send the link. There's a link. There are two separate links. There's one for the manual vacuum aspiration tool and one for the medical abortion tool that I'll try to paste in the dialog box, and it is available to anyone who would want to access it online.
Great, thank you, Patrick. I have another question for Mariana. Mariana, when you were speaking about the about your project, you were talking about how you recorded attempts to register mifepristone and misoprostol, and I'm wondering if you can tell us how you were able to look at failed attempts to register.
Hi. Well, the failed attempts were reported by confidential interviews that we had with people at registration agencies. We were not able to, even we tried, to talk to any of the pharmaceutical companies' responsible people. We tried to, but a lot of them relied on their commercial secret or confidentiality in order not to release that information. But through the interviews that we had with some of the agency's people, they told us there were attempts, but all of them failed. In any case, from the successful stories, what we found is that when the ministries of health are able to explicitly provide background for having those drugs registered, or if, like in the case of Colombia or in Uruguay, the change in the law includes the right for beneficiating from the advances of scientific knowledge as a human right. Those were facilitating factors for those drugs to be approved. I don't know if that answers the question.
Nathalie, are you still there?
Oh, sorry, I was muted for a moment.
Oh, yeah.
Mariana, I had one more question, which was, are you sharing your results with governments and elsewhere? Are you disseminating widely?
Yes. First we made this report available through the CLACAI website, and we were surprised by the number of downloadings downloaded hits that we had through that document. Then we made a presentation at the regional meeting that I had in November. I'm sorry, at the end of October this year, along with a NAF conference in Lima. So that reached a really wide audience, also coming not only from the public sector, but also from the private sector. And yes, we sent the report to all the people that were kind enough to be part of this study, and also to the ministries of health of the 6 countries.
Thank you. Thank you for that, Mariana. It'll be great to see what happens with that work as it gets out there. I have one final question. I think we have time for maybe 1 or 2 more. So if anybody has a question, please try to get it into me quickly. Heather, there's a question for you about whether there's usefulness of having some kind of forecasting tool or quantification guide to address one of the recommendations that you had in your slide.
Sorry, hi, thank you for that question. And yes, I think there is, you know, these tools are certainly helpful. And, you know, I think that I'm not sure if the question was for both supplies or one in particular. But I think that's something that the group can discuss. And, you know, there are some tools that exist. So, so that needs to be looked at, and it could be a manner of rolling out existing tools, adapting existing tools, or even creating new ones. So that I think that's really something that needs to be taken a step further. Thank you.
Great, thank you. I have one final question that was typed into the chat box that says it's from me, but it's not, was whether Mariana is able to share the tools they used in the assessment. And I think she said it was on the CLACI website. Is that correct, Mariana? Mariana, you might be muted.
Sorry, I just pasted the link in the dialog box, and yes, the instrument is part of the report, so you can, and I'll be happy to answer any questions that you might have on that.
Terrific. Okay, well, thank you very much for all of you for reporting on your excellent use of funds for the innovation grants that were awarded last year. And so we'll move on to the second part of our meeting, and I'll turn it over to Jen Blum, who will be moderating the rest of the panel.
Thanks.
Okay,
Nathalie, I'm just wondering,
are you going to ask about the question boxes, Jennifer?
Yes, I was just going to note on the question box on the chat, there was about 4 or 5 questions. I don't think we got to. They were, did you see the question and answer box, or are you just looking at the chat box? Nathalie? Oh.
I was looking at both, but I don't think I saw what you're talking about.
Okay. There's 2 questions from Sonia and 1 from Genesis Luigi.
Do we have
Nathalie,
time?
If you want to.
Do we have time for maybe one more?
I think we do. We could do maybe one more because we're okay on the time right now.
Okay, so here's one for Erica. Can she comment on what were the motivations for the Kazakh policymakers in wanting to reduce the number of visits? Was it an economic rationale? And second, what are your thoughts about bundling MA and MLPT products?
Hi, thanks very much for that question. I I think some of it was just that they raising their awareness to sort of the current standard of care in other places around the world, and just letting them know that sort of things have moved on. So I think part of it is just, you know, under the Soviet system, they're just used to following, they're sort of very rule following folks. So this is how it was done. They were continuing it. It was a very sort of patriarchal system of medicine, and then they're willing to move away from that. So I think certainly the MOPT can help eliminate that fourth visit for the follow-up visit. So they were interested, and certainly in talking to the providers after the study, you know, they had a very positive opinion of it. And at the dissemination meeting, the Ministry of Health folks are very interested as well. So as they start doing their next guideline revision cycle, you know, this information will all feed into that. But I think it's certainly possible, and we're going to push more for integrating the MLPT into medical abortion care. So I think there's certainly an opportunity there.
Okay, so there's another question that's a very interesting one. I think this goes to Heather. What other points of the supply chain can be susceptible or show abortion stigma manifestations? Although Patrick might have a comment about it as well. Heather?
Thank you. I'll go first. So, you know, one of the examples that came up from a stakeholder interview was that in Kenya, there was an issue where MVA kits were in the budget and were available in country, they were in the budget, and there was an individual in the Ministry of Health that would not sign off on placing the order, and so you know, I think it exists in many places, in places that we may not be thinking about or have focused on previously. So exploring the issues of stigma in other places along the supply chain that we don't typically look at is worth exploring. Thank you.
Yes, Nathalie, for me, yes, we have had such cases also in some of the countries where we've been working, and which has led to having the medical abortion drugs being distributed to facilities within the public health sector using a parallel distribution system, because at times you have people who just not take it as they are taking any other commodities or medicine because of their own, they say their own personal beliefs, and they think they are contributing to a bad thing. But also just at a facility level where services are supposed to be provided, and you'll find pharmacists, people who are looking after medicines at that facility, not wanting to keep the medical abortion drugs in the pharmacy, and this is based on their personal beliefs. At times they just hide it and wait until it expires. So that those are real situations that we've seen affect the supply chain significantly.
I think Nathalie is muted again. Oh, okay. So thank you everyone for the great question and answer, and for the 4 fantastic presentations, and for sticking to the time so far. We're going to now move on to brief presentations of other projects that relate specifically to abortion commodities that we thought would be of interest to bring to this group, so we could discuss them in the context of future work for the abortion workstream. And with that in mind, I'd like to first invite Nene Fofana from PSI to give her presentation on decreasing maternal mortality and morbidity related to unsafe abortion in West and Central Africa. And as a reminder to all the presenters in this section, You're going to have approximately 6 minutes for your presentation, and I'll give you a 2 and 1 minute warning. Thank you.
Good afternoon, everybody. Bonsoir à tous, and thank you for having me present today. I'm very excited to join.
Nene, I'm having a difficult time hearing you. I don't know, can others hear you?
No, I can't hear Nene either.
It looks like she's muted, perhaps.
Nene, can you check your phone to see if you've accidentally hit the mute button?
She just logged off. I know she was having a little bit of connection issues, so I know we talked about her using phone as a backup. So I propose that we go on maybe to the next presentation and circle back if Nene comes back online.
I think that sounds like a great idea. We can include her next. So if you could just push the slides forward, Sophia, I'm going to now introduce Kartik, who is going to be speaking about IPPF's Global Medical Abortion Commodity Database.
Thank you, Jennifer. Should I continue?
Please do.
Thank you, Jennifer. Hello, everyone. My name is Kartik, and I'm a consultant with IPPF, and I'm going to talk to you about one of our exciting projects, which is about the development of a medical abortion commodity database. Next slide, please. Thank you. So just to give you a little bit of background, IPPF is advocate and a large service provider of safe abortion services integrated within sexual reproductive health services. And we have about 90 member associations as of 2016 that currently offer safe abortion services. And one of the things that we found over the last 4 years was looking at outcomes for medical abortion. We found that there were a lot of concerns that were raised either by clients coming back or by service providers that were explored with a medical audit. And one of the things that we did systematically when we looked at the case sheets and interviews with the providers and the clients was we found that there could be some issues with the quality of medicines that was being used, especially misoprostol that was being used, which could affect the experience for the women and the providers. And based on that, we actually collected samples from point of care where it was used, so either from a pharmacy or from our own clinics where it was stocked and used. And in partnership with Concept Foundation, we actually undertook drug testing for the content of the misoprostol tablets, different brands that were picked up from different countries. And one of the things that we found was that we identified that there was a lot of issues with either poorly manufactured drugs or drugs that were spurious. So we had instances where the sample that we picked up from a pharmacy turned out to not have any misoprostol in it. And then in some places we found misoprostol degradation products, and we found that the content in the tablet was not consistent with the labeled content. So based on this, we were thinking about what do we do? And we wanted a practical solution that we could implement within our clinics, for our service providers, and so on. So that's where we thought about the idea of developing a commodities database for medical abortion drugs, with a primary focus around what is available in country in terms of different brands of mifepristone, misoprostol, and Combipax. And specifically, we also wanted to get a better understanding of the quality of misoprostol that's currently available out in the market, and what can we actually recommend to our providers in the absence of a product that's either WHO pre-qualified or is approved by a stringent regulatory authority. And we also realized that this was a big gap, because one of the things we did was in Kenya, in Pakistan, when we had this issue where we identified that substandard products were being used and was in circulation, we wanted to ask experts for advice for alternative products, and we really didn't have enough information to say this was a better product than what we were already using. So we also wanted to make sure that we have this database that contributes to the overall knowledge of medical abortion commodities. And as a group, how can we use this information to advance the quality of the commodity, the availability of the commodity, and ensure that the use in practice is much better than what it is currently happening in some parts of the world. And as I said before, we wanted something that was practical, that was something that we could implement within our own networks and clinics as well. Next slide, please. So we are currently in the process of developing the database, and we had identified 2 specific objectives. The first objective, as I mentioned, was to increase access to comprehensive country-level information on high-quality medical abortion commodities. And when I say medical abortion commodities, we were focusing on mifepristone, misoprostol, and the combi packs, where mifi and miso are co-packaged. And the second objective that we also wanted to come out of this project, out of this specific project, was we wanted to make sure that we use this information once we've started mapping the availability and the quality issues. We also wanted to identify specific actions that would lead to an increase in the availability of high quality medical abortion commodities. So for example, we wanted to identify high quality products that we could then increase the availability of in different countries, or look at countries where there are currently no quality assured products that are currently available, and then ensure we work with a different set of actors and stakeholders to ensure that high quality products are registered there. Next slide, please. So we are currently working with Gynuity Health Projects and Concept Foundation, who are the other 2 technical partners working with IPPF, and together we are developing this. We are hoping that the database should go live in May, middle of next year, middle of 2018. So about May 2018, we hope to have the launch of it. We are currently in the process of collecting data on this, but what we envision as an end product is an online searchable database, which is going to be free to use. It's going to be hosted as a website with links on each of the IPPF websites, and hopefully on Gynuity and Concepts websites as well, where people can actually go in and search by country for the different brands of mifepristone, misoprostol, and the combi packs that are available. And once you do a search by country, then you'd also be able to see other additional information, supplementary information on those different brands. So for example, you'd be able to see the presentation of the product, the dosage forms, and whether the prescription is needed or not for purchase, and so on. And one of the unique pieces in addition to this availability is an information on misoprostol's quality. So currently one of the challenges we do have is we have very few products of misoprostol, brands of misoprostol that are WHO pre-qualified or available or manufactured by a manufacturer who has stringent regulatory authority approval, so something that's quality assured. So we also are trying to work around a system of assessing the quality of misoprostol so that we will have that information in a simple, practical way for end users who use the website. So it could be a doctor who's prescribing misoprostol in Kenya, or it could be a procurement manager looking for the suitable product to use within their supply chain at the country level, or it could be a global supply chain where they identify high quality products. So we want to have something around the quality of misoprostol that's practical and usable to say, yes, this is there is information to say that the product has some level of quality or is quality assured. So that's the other unique piece that will be available on the database as well. Next slide, please. So in general, as I was mentioning, we are currently in the process of collecting data to compile the availability of products, and we hope to, and we are having a meeting scheduled in end of March, right after the RHSC coalition meeting, where we will actually be able to identify what is currently available and then also discuss around the quality aspect of misoprostol. So one of the big requests that I do have here is, I know a lot of the previous presentations and others have worked on this issue, and one of the big requests from IPPF is that we would really appreciate if any of you had information at the country level around the availability or any information related to misoprostol quality. We'd be very happy to receive it and see how we can work together to make sure that this resource is useful for the overall community well beyond just IPPF. Thank you.
Thank you very much, Kartik. And I can just say on a personal level, I just coming back from Vietnam, where I had an opportunity to start to collect some of these products and work with our local consultant. It is interesting when you see what is available, particularly when you get outside of the main urban centers. I understand that Nene's audio is working now, so I'd like to go back and give again time for Nene Fofana Sise from PSI to give us her presentation on PSI's work in the region. So please, Nene.
Thank you, and thanks to everybody for your patience. The power went out. I don't think there's any other way around that, but thank you. So basically, I was gonna just give an overview of the work that PSI has been doing in the region. And again, the idea behind that is for us to really contribute to this forum. I've seen from the recommendation that were presented earlier and also from the IPPF database that there's a lot of opportunities for us to not only contribute to the global work, but also to bring a lot of this expertise back to the region, where that West and Central Africa specifically, where, you know, as you know, the needs are, you know, huge. So quickly going to the next slide. I just wanted here to show a little bit of the PSI program. And the PSI program is basically looking at several aspects. We are definitely working in family planning, as you know, to make sure that there's comprehensive sexual education and family planning services available, especially led by youth and for young people, which makes sense in this region where more than 50% of the population of each country is definitely less than 35 years old. The other prong, and which is very of interest to this group, is really the product distribution part. So PSI does work in product distribution, and we've had a history of working in social marketing of several products. And we've applied the same discipline to safe abortion work, where we not only work in making sure in every country where we work that we bring misoprostol if there's no misoprostol on the market, but we also look at opportunities to bring in the miso and mife combination path where we can. There's also an aspect of service delivery. We train providers, we provide coaching, and we provide assistance to providers to be able to offer safe abortion services as well as post-abortion care services. In terms of system strengthening, we work closely with Ministry of Health, like a lot of you who presented before me, but also in the audience, on contribution to the national health system information, and also in terms of equipment and assistance through directly PSI programs or working with other partners such as DKT and others in countries who sometimes have the equipment available. We also are growing our interest or activities in advocacy because, you know, as others have mentioned, there are several issues. Advocacy is definitely important in terms of registration, protocol and norms revision, and you know, global issues around misoprostol procurement. Please, next slide. Can we go to the next slide, please? So this is just this slide just describes the continuum of the abortion work for PSI. We, especially in this region and everywhere in the world, feel like there are several steps to get to safe abortion. And the startup step is really making sure that misoprostol is available and registered in the country. If it's not done by other partners, we will work with the Ministry of Health and all stakeholders to make that happen. The second step is around making sure that people know that misoprostol is available and it's being distributed both in the private sector and in the public sector. We focus a lot on the private sector because we believe that private sector goes usually further beyond and is accessible to a lot of other people. And then we also work on safe abortion, on harm reduction. And harm reduction is the portion of service delivery where we train providers to be able to go beyond the stigma, beyond a lot of the issues that were mentioned by others earlier, to be able to offer comprehensive information on misoprostol or on safe abortion in general, and then have women return and offer and get PAC services at the health centers. The last portion for us is, of course, to have MIFE and MISO registered and also have an environment that is supportive of safe abortion. There are several countries in Asia where this is already happening, where the laws are different, there are less restriction, and in those countries we distribute MIFE and MISO combination, and we work also to continue the advocacy for women's rights around safe abortion. Then we go to the next slide, please. So this slide doesn't show very well, but it's just to show the scale at which PSI has been distributing misoprostol since 2008, and this is an ongoing trend. and we will continue to work in this area. So this is just a snapshot of the quantity and the volume of misoprostol we've been moving through the different countries where we work. Can we go to the next slide, please? So this slide just also summarizes some of the work we've been able to do with private providers. And this doesn't count the service provided in the public sector or the number of public providers trained. It's just, again, an overview of the work that we've been able to do. And this is mainly Africa with a couple of countries in Asia, 3 countries in Asia, I believe. The other very important thing here is that we're really working hard with the providers to increase the number of women who access family planning after post-abortion care services. And we're really trying to push that target to hit at least 90% of the clients that we serve. Next slide, please. So this is just an overview of the post-abortion care program that PSI has in the world, and also the safe abortion program that are mainly located in Asia and a couple of East African countries. One thing I want to flag though for the West African countries and for all the countries that have the little star is that those are the countries where we work in harm reduction, where we train providers to actually offer counseling on misoprostol and where to find the products, and we encourage women to return for post-abortion care services. Next slide, please. So this is the end, and again, I want to thank you for your attention to this presentation. The goal again is to just show a little bit of the scope of the work that PSI has been doing globally and in the region. We look forward to working with this group and others on the recommendations that were presented earlier by Heather, but also doing more in-country work in terms of synergizing in-country to really strengthen the safe abortion commodity supply. Thank you.
Thank you, Nene, for that very interesting presentation. And good thing you dialed back in because you were very clear the second time. Very easy to hear you, so you had a good connection. So I'd like to turn to our final presentation of the day, which is actually going to sync quite well, particularly with the presentation we just heard from Kartik. And we'll be hearing from my co-chair, Nathalie Kapp, who's going to report on findings from a report on misoprostol quality that's been led by Ipas.
Thank you so much, Jen. So this does go very well with Kartik's presentation, and I think we've all heard in the past few years that there are reasons to worry about misoprostol quality. Can I have the next slide? So based on reports and publications of questionable misoprostol quality, Ipas commissioned consultants to conduct and produce a report which provides a snapshot of misoprostol quality issues just this year in 2017, focused on the drugs used for medical abortions. The findings are compiled from a review of established research and online sources, as well as interviews with over 35 key individuals to identify many problems not yet addressed in the published literature. And what the consultants did was to ensure a common language and comprehension during the interviews that they held with informants. They developed a misoprostol quality framework consisting of 7 levels of factors affecting misoprostol quality. Next slide, please. The framework is visible here, and you can see the 7 levels include policy and regulation, manufacturing, procurement, supply chain, both network and non-network affiliated providers, and women's perceptions of quality. And this framework was meant to serve as a way to ensure that perceptions and assessments of quality and what affects quality were included in from all aspects. And a variety of questions are listed here that they brought up with the expert consultants or the expert informants that they interviewed at each level of this framework. Next slide, please. So this is actually quite a long report, and I'm just going to highlight a few things. Here are a few of the findings. There's over 80 manufacturers of misoprostol globally. and only a small number are WHO pre-qualified or have SRA approval, and we heard that just a moment ago from Kartik. Some are capable of producing misoprostol that's of good quality when it's continually tested, but beyond this small number of manufacturers, there's a large number of variable products, many of which are filling the black market. Now, misoprostol is not actually a complicated recipe. It's not difficult to make, but the manufacture and maintenance of quality downstream is crucial because misoprostol, it dissolves in water and it's susceptible to hot and humid environments. So porous packaging means that the product degrades. And then I want to highlight that there's only one pre-qualified SRA-approved source for the misoprostol API. Next slide, please. Few more findings. Regulatory capacity and post-market surveillance, which is strong in some countries, is weak in many countries, and particularly in the global south. With a myriad of manufacturers of variable quality, deciding which product to buy is actually a really critical decision for programs, and the safe choice is to buy an SRA product or a pre-qualified product, but these are more expensive relatively. Most people who were interviewed for this report were more worried about misoprostol in the supply chain than they were about other drugs. But misoprostol is susceptible for quicker degradation, and so the packaging matters. From women's perspectives, they want an inexpensive product, and of course they prefer to have a quality one. And then the providers that were interviewed and assessed during this report really have variable skills to discern quality of drug. Next slide, please. The overall conclusions, and I think that this makes a lot of sense, that the higher the quality of the product when it's first manufactured, the higher the quality is likely to be when it reaches the end user. For manufacturers, manufacturing for an international international market at quality standards is expensive. And so there has to be a reason for manufacturers to do this. They need a market, and they also need a little bit of competition. Next slide, please. So there were a number of recommendations, and here just kind of a few. First, there's a need for donor understanding and coordination in aspects of misoprostol quality, and this is true because big donors really drive quality in a lot of the international programs. There's an international monograph for misoprostol that was published by the World Health Organization in 2015, and this hasn't been disseminated, so there's a lot of country programs, or not programs, but country manufacturers who are unaware of the monograph, and this could be more extensively disseminated. There's a need to follow a structured risk management to approach in close coordination and information sharing amongst organizations who use misoprostol. It could be useful to conduct another quality study in some key countries to support Concept Foundation's work, but I think given the work that's being done with the database that Kartik just talked about, maybe that will supplant this recommendation. Finally, building in continual testing for abortion network products by ordering drugs in different places and sending them for quality testing is a way that we can do kind of intermittent looks at quality. Donors could build this into their surveillance as program requirements, and this could affect the quality that are being used by programs. And I think that's my last slide, and thank you for the 5 minutes of time to be able to talk about this report. And I just want to say that that as we're just in the process of finalizing it, and when it's finalized, we'll try to widely disseminate it, because I do think it has some interesting and important information for all of us.
Thank you very much, Nathalie. Very interesting. And I think one of the things that perhaps the workstream can do is try to pull together a compilation of these important documents, including the WHO 2015 document that you mentioned, and maybe make them available to members of the workstream so that we all have some of the core documents on hand to use with our organizations. I'd like to open up for just a few minutes. I'm not seeing any questions in the question and answer or in the chat. So I'd like to open up if anyone has a question. And while we are waiting to see just for a few minutes of questions, if any questions come, I did have a question, Nene, for you about the PSI work. Could you tell us a little bit more? You mentioned that medical abortion and misoprostol are being used in the various countries, but can you tell us a little more? Are you able to tell us how or where PSI sources their medical abortion products, and are they all from the same distributor, or are they from different distributors in different countries? It'd be interesting to hear how an organization such as yourself identifies which products they're going to use in their program.
Definitely. So PSI work through qualified distributors and manufacturers, I'm sorry. And we basically work with Acme and also with, and what we've been doing is we are working, so we basically procure from the manufacturer and distribute in several countries where we work. We work with two manufacturers, and depending on the country, depending on the regulation, we adapt the brand. However, we are working on a global brand that we will be launching soon, and that global brand will basically cover all the PSI countries when it comes to misoprostol. And for the miso combination pack as well, we work with a global manufacturer.
When you launch your global plan, will that include a combi pack, or is it going to be separate misoprostol misoprostol products?
So it's going to be separate for the moment. It's going to be just the misoprostol that we launch as a global brand, and following on to that, we will be working on also a global brand for the combination pack.
Great. I'm not seeing any other questions. One thing I can answer, Mariana has asked a question to Kartik. Will he share the link to access the database? Kartik, do you want to answer that quickly?
Sure, Jennifer. Thank you, Mariana, for the question. So as I mentioned, we are in the process of developing the database. So we should have wireframes where we upload some test data to check out the website in early February. But one of the things that I've made a note for myself is actually to reach out to you beyond the meeting to see if the information you collected for your project could actually feed into the process. We did finish data collection in Colombia, but we would really like to hear about your experience and what you found in the other 5 countries as well. So maybe we can continue the conversation. And once it's ready, we will make sure that the link to the actual database is widely available.
Thank you. I'm going to move on. I see you asked a question, Nathalie, but let me move on because we have 3 minutes left, and then I know everyone has other commitments. So if we could go on to the final slide. And I wanted to just talk briefly, first of all, thank everybody for the very active participation today in the questions. And there are some other questions coming in that, of course, we will continue to answer. And I think it's really wonderful news that we know that we'll be able to convene together in person in March. And Nathalie and I were just chatting during the course of this webinar saying that these kinds of things like discussing work plans for a work stream often best happen in person. So we're looking forward to having time to do that with you all in the very early part of the next year in very sunny, I'm sure, Brussels. But I did want to tell you that we have had a chance to draft a sort of an overview of a high-level framework for this work group. And I want to just talk briefly about it. We drew heavily on work plans that we received from other caucuses and other work streams. Within the Reproductive Health Supplies Coalition, we found that some work streams do not have actually formal work plans, but I think that we feel it'd be better to have something in writing so we can be able to assess whether or not we're making progress and what our sort of key objectives in coming together and forming this new group, you know, what the meaning of it all is. So we see the overall goal as increasing access to an awareness of high quality abortion commodities globally. I think we've done some of that today just within our smaller group. And the purpose to implement collective actions to increase, expand, and improve access to high quality, safe abortion commodities. We've envisioned 4 outcomes. And again, I mentioned this is a draft. So we've received some comments on email and from our earlier conversation we had a few weeks ago, but we're very welcome and open to new comments and additions to this outline that we have that will help us then layer on to the next step, which will be thinking about the activities that we're doing both individually as organizations and also collaboratively within the workstream to help us achieve these outcomes. But the first outcome would be to increase knowledge of high quality abortion commodities among coalition members. I think that's a very important thing to think about doing. And then secondly, that abortion commodities become integrated into broader coalition discussions about reproductive health supplies. Recognizing, of course, that this is a political issue, we also want to see as much as possible that abortion should be integrated within the larger discussion of reproductive health supplies. And I should say that by having a special forum about abortion commodities, it's not in any sense to I would say, separate us or silo us as an individual group, but rather to think about ways we can integrate within the broader coalition. The third outcome will be to generate new evidence and disseminate existing evidence on quality products. And fourthly, to increase mifepristone, misoprostol, and MVA availability globally. So these are the outcomes that we are thinking about, and we look forward. We have actually no time left today, unfortunately, but I'd like to, if anyone has any specific questions, perhaps it's best to send those questions to those of us that are to Nathalie and myself. And unless there's a specific question, maybe I'll just say a few closing. We're running out of time. I apologize that we are so short on time, but I would just like to thank everybody for participating very actively in this webinar. I think it's an achievement of our group already to be able to come together in this way and hear the various work that's going on. I think it also affords us additional time in March to have a more active conversation about the work stream, because part of our initial agenda was to present these, to have these presentations. And so now we have done that, and we can have a more active conversation with all of the members of the work stream in March about how to move forward, and also in the coming months. So what I'd like to propose is that Nathalie and I will send this outline to all of you, but perhaps even with another section for activities and any ideas that you have about modifying or editing the goal, purpose, proposed outcomes, and even any activities that you can think of that you, your organization, or that you know of others that are working on that might lead towards that already. If you could begin to populate that area, I think it'll give us a really good point from which we can all discuss in March. And on that note, I'd like to very much thank Sophia for organizing this excellent webinar, and my co-chair and co-moderator Nathalie for doing such a great job, and also to NURHT for her new stewardship and lead in this the NURHT group. We look forward to working with all of you in the coming year. So thank you very much.
And thank you so much, Jennifer and Nathalie. This has been really excellent, and I am excited about all of our next steps as well. Thanks, everybody. We'll end the webinar now, and we'll be circulating a recording.
Thank you. Bye.
Thank you.